everybody. Welcome back to This Week in Global Health, otherwise known as TWiGH, which is a regular video series that discusses relevant and current topics in global health. Today, we're going to start a special series featuring leading topics coming out of the latest publications from the Disease Control Priorities Network, starting with essential surgery and global surgical disease. I'm Jessica Taff, and I'm hosting this show today from the Washington, D.C. metro area. And to help discuss our topic today, I have my fellow TWiGH colleague, Solzhen, here, and two guest panelists who are experts on essential surgery. Now, everybody, why don't you introduce yourselves?
Hi, everyone. I am Solzhen Bali, and I'm joining you on a warm and sunny DC evening with Jessica as a co-host for this show.
Hey all, my name is Mark. I am joining you from a very cold Denver, Colorado. I am the research director for Harvard's program in global surgery and social change, and I was one of the authors on a few of the chapters in the DCP volume on essential surgery.
Hi guys, I'm Jamie Henry, and saying hello from Florida, and I'm really happy to join you guys. As a backgrounder, I was born and raised in the Philippines, and that really informed a lot of my advocacy and work in essential surgery. I was the founding executive director for the Global Alliance for Surgical Obstetric Trauma and Anesthesia Care, and also a board member of the International Collaboration for Essential Surgeries. I'm happy to be here. Thank you.
Awesome, thanks. Well, Solzhen, before we dive into today's topic, I thought maybe you could give everybody a background on what the Disease Control Priorities Network is, and yeah, that way so we understand why we're talking about essential surgery today.
Absolutely, Jess. So basically, DCP3 is a third edition of Disease Control Priorities that is actually an up-to-date comprehensive review of the efficacy, effectiveness, and cost-effectiveness of priority health interventions that can help policymakers in priority setting and resource allocation to address global health challenges. In fact, the Disease Control Priorities is being funded by Gates Foundation, and it's being led by University of Washington as well.
Solzhen, so it's University of Washington, and it's also the Institute for Health Metrics and Evaluation. And right, you were saying they put out these a lot of publications on like effectiveness and cost effectiveness, blah 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 blah, right? But they publish these assessments in 9 volumes, and they're focused on the interventions for different disease areas, including essential surgery. And what I think was fantastic about it is that once the publications are actually published, they're all available online for free, and you can check them out at DCP3.org. So that's really an exciting thing about it, is that it's all available. And but moving forward, I just want to say, look, we're focusing on essential surgery today because this is an important and emerging issue in global health that has really started to get attention. In fact, Paul Farmer and Jim Kim have called it the neglected stepchild of global health. And the reason why we focus on it and why it's really not neglected, but why it's tragic that it's neglected, is that 2 billion people lack access to emergency and essential surgical care. And most of the gap is in rural and marginalized populations in low and middle income countries. And this is a real problem because a lack of surgical care just for simple treatable conditions can lead to serious and life-threatening conditions, or poor quality surgical care could actually lead to chronic disability that would affect someone's quality of life and their economic potential.
It's really interesting, but while we're talking, it's also very important to define exactly what we mean by surgical disease, because even experts don't agree on one definition, and it can be quite confusing since some illnesses only become surgical disease when they're neglected long enough. So for example, very often essential surgical conditions need to meet the following criteria. Are they primarily or extensively treated by surgical procedures? Are there other care options? Do they have a large healthcare burden? Or can they successfully be treated or eliminated using a surgical intervention? So, when we talk about definitions, is that what exactly it is? Or Mark, is there more to it?
Yeah, so I think this is, first one thing that before I even go into this, the estimate that Jessica gave earlier, that 2 billion people don't have access to surgical disease, it's an estimate that comes from a paper written by Funk a few years ago. in which they looked at the global distribution of operating rooms only and found that 2 billion people don't have access to an operating room. We are going to talk later on in this program about what it means to have access to surgery in general, but that's only one, having an operating room around is only one of the many aspects of actually getting surgery. The Lancet Commission on Global Surgery, which was published just a month after the DCP, redid that estimate. And the estimate is actually that 5 billion people around the world don't have access to surgery, which fits actually really well with what you see on the ground. Because if you think about the estimate that Jess talked about, that 2 billion people don't have access to surgery, it implies that most of the world is doing just fine with surgery. And if you've lived and worked in countries, in low and middle income countries, you know that that's not actually reflective of what's on the ground. To what Sultan just said, I think this definition of surgery as things that can be treated with a surgical operation, things that have a large disease burden, and things that are primarily treated by surgical procedures is way too narrow. And I'll give you an example of why I think that. If I were to walk outside right now and slip and fall and hit my head, then I hit my head, lose consciousness, and then brought into the emergency room, I would be seen by a neurosurgeon, most likely. And most likely that neurosurgeon would decide to do nothing with me, even if there's blood inside my head, would just sort of wait to see what happens. And likely nothing would happen and I would not be treated surgically in that definition. But the only reason the neurosurgeon can do that is because she's got a fully staffed sort of surgical system behind her that she can treat me non-operatively. Now, does that mean that my brain bleed is considered a non-surgical disease? And I'd argue that it's not. It required the expertise of a surgeon, even if I never actually ended up in the operating room.
So I think it is important to define surgical disease for sure. And under that, even to go further and say, what do you mean by an essential surgical condition? And the DCP3 has really done a great job in terms of really saying, all right, these are primarily extensively treated by surgical procedures and other surgical care, have a large health burden, and can be successfully treated by surgical procedure. That's good, but it does exclude some other conditions by which, to some people's minds, it's non-surgical, but when you say surgery, it implies cutting. It implies manipulation. It implies a lot of things that is very invasive. And Mark has really aptly pointed out an example of one of those conditions. And there are many, many other conditions. And one example would be a small bowel obstruction from scar tissue inside your abdomen. And for most cases, you can actually treat it non-operatively. You don't need to cut, and it gets better. So if by adhering to a strict definition, it does exclude this kind of condition, and I think that it will be instead more apt to think about surgical problems that a surgically trained provider can address that no other medical providers can or is trained to do.
There are definitely things that that are considered surgical conditions, or like you said, that can be treated by surgical procedures like cancers or orthopedic injuries or disfigurements from burns, congenital defects, like from cleft lip and palate, even like blindness from cataracts. That's all requires surgical procedures. But I agree with you. And I think that's really important points that you talk, saying that it's a really broad array of conditions, and there needs to be a wider way of appreciating the role of surgical and surgical capacity in global health. But let's just say, like, there is a lot of attention to surgery and essential surgery. And everybody, that was my cat, and she didn't get put away. So there you go. A little blip, and that's how you know we're live. But anyway, I was saying about the different conditions and how, the fact that it is so broad really is challenging. And the fact that people are bringing that up challenges our kind of binary way of looking at it. And so I want to ask Mark and Jamie, why set it apart like this, as opposed to really instead just talking about increasing surgical capacity within all health conditions and all of global health?
the truth is, I don't think we're trying to set it apart in the way that you have just set it apart. I think we very firmly believe, one of the definitions that we have used in at least one of the chapters in the DCP volume on surgery is that a surgical condition is any condition that requires surgical decision-making at some point in its disease course, which would then cover a lot of the things that Jamie mentioned, like a club foot or a small bowel obstruction or a subdural hematoma. Even though they're non-operative, they require some sort of surgical decision-making, even if the decision is, let's not operate. We're not at all trying to set aside a subset of conditions that these are surgical conditions, because one of the most important things about surgery is that it is cross-cutting. It doesn't lend itself to a disease-specific group because it's a procedure, because it's a treatment as opposed to a disease. And we're focusing on scaling up surgery in that way because we really don't want to make the point that the world should focus on surgery instead of focusing on tuberculosis or instead of focusing on maternal health, but that the world should focus on surgery because we're not going to be able to achieve our maternal health goals if we don't actually scale up surgery in the entire hospital. We aren't going to be able to treat some really advanced forms of TB if we don't have surgical procedures. We're not going to be able to treat cancers, et cetera, et cetera. The list goes down. So surgical conditions aren't a separate disease entity at all. It's surgical treatment that is part of the health system that we're working on.
I think it's important to focus on surgical care as a separate disease entity, and that's because if we just stop now and look at the astonishing lack of progress in the rollout and scaling of surgical systems in developing world in the last 40 years, you would see that there's some surgery is fundamentally different from everything else. And there's a reason why we need to focus on it as a separate entity. If you look at it from a healthcare standpoint, yes, it does address disease at the very end point, right? Like when all else fails, will surgery save this patient's life? And we throw in all our resources to make that happen. But if you actually look, if you put on your public health, Minister of Health hat, right? And you're thinking about delivering surgical care in the remotest and poorest of areas, right? It's a different thing. The supply chain is different, the training is different, your people are different, the transportation is different, everything is different. And separating out the simplest and the most basic of surgical procedures that everyone should have access to regardless of their ability to pay, really. And if you really, really narrow it down to a very, very focused set of interventions and show them that it's possible to provide that, then several things happen. First, you can't help but invest in the health system as a whole. So that's one of the things that happens. You can't help but make sure there's clean water, make sure there's sterility, that you train people. And getting that to fruition actually then shows the Minister of Health it's possible and shows the community that it's possible. But from there, you can actually then iterate and start to build on that. And then you get into the more complex procedures later on. But unless you're able to really step into that primary role and to reframe surgery as an integral part of primary care, then it's something that the Ministers of Health would just say, well, you know what, it's too hard. And in the 40 years will go by and nothing's gonna happen.
Right. And yeah, that brings us kind of what you were saying is that there is this idea that is hard. And that brings us into what are the myths about the surgical disease burden, the global burden of surgical disease and essential surgical procedures and stuff like that. And the first one, we'll get, we've already talked a little bit about the burden and whatnot, but that's definitely one of the myths, is that the burden of disease due to surgical conditions is actually quite low. But as we've already been discussing, it really isn't. And it's not limited to just, specific health issues. I like that already we've touched on this and tried to dispel these myths. But yeah, that's an important thing to bring up, is that there's a very large burden of disease, and that's primarily and extensively treated through surgery. And what the DCP volume on essential surgery has brought up is that if full provision of essential surgical conditions was given, that this could avert about 1.5 million deaths a year, or 6 to 7% of all avertible deaths in low and middle income countries.
You know, Jess, since you mentioned the number of deaths essential surgical disease could avert, we should also describe what exactly are the essential surgical procedures. Things like dental procedures, like extractions, you know, so important. Basic obstetric and family planning procedures like cesarean birth, vasectomies, fistula repair, general surgery, such as circumcision, appendectomy, hernia operations, and treating various types of injuries and congenital physical conditions are part of it. There are many more, in fact, in total 44. And what's most notable is that most of these could be done at first level or district hospitals, if not done at a community health center.
I'm going to be the naysayer here. That 6 to 7% estimate is also way too low. This comes from one paper that looks at exactly what you said, Jess. It looks at the number of avertible deaths from a limited set of surgical procedures at the first level hospital, which I agree with Jamie is where we should start. But overall, that 6 to 7% number is essentially us telling the world, hey, 94% of your diseases don't need us, which I don't think any of us truly believe, that only 6% of patients that enter hospitals need surgery. And again, so if we go back to the definition that we were using before, which is if a disease is surgical if surgical decision-making is required at some point, then that number jumps from 6 to 7% all the way up to 30%, which, you know, at least to me feels like a closer number to what reality is. And I don't think any of us thinks that it's, you know, that 94% of the world's diseases don't require surgery.
I agree with Mark. So yeah, I think that the DCP3 estimate for the global burden of deaths that could be avertible by easily treatable conditions requiring surgical care is, while it is a good figure, I think it is an underestimate. So take, for example, the global burden of disease study, which cites that injury alone causes 5 million deaths per year. And we know that about 90% of those deaths are found in developing countries. And if you would think about, well, out of all those deaths, which of those are avertible? Let's say 40% are avertible, right? You're already having a 1.6 million number out there just from injury alone. So it probably is an underestimate, but I think it's a good, you know, it's a good place to start with, to just start to uncover the magnitude. And if you think about it, that's just the tip of the iceberg, right? Underneath the deaths, where surgery really shines is in averting disability, right? Think of all, you know, the kids born with cataracts that are blind and you make them see, right? Think of all the injuries, the fractures that you fix. Think of all the club feet that you fix, all the clefts. You're averting a lifetime, right, of disability. And you can just, I mean, I can't even like begin to fathom, right, the amount of, you know, the figure of that. So if we're saying burden, right, like there's not even, it's a no-brainer, right? It's not even an argument, right? So yeah, so I think that any figure that fails to really account for the amount of disability that surgery can avert is painfully inaccurate.
I'm glad you mentioned that, Jamie, because, you know, obviously universal coverage of essential surgery is really important for achieving universal health coverage and making surgery affordable. In fact, I remember reading the estimates that implementation of universal coverage of essential surgery would require about $3 billion per year of annual spending over current levels. And it would have a benefit to cost ratio of over 10 to 1. That's amazing return on investment. Yeah. So completely agree with you there.
I'm glad that you brought up costs, Sulzan, because that's the other thing that I wanted to talk about, another myth, right? So we were talking about, yeah, why haven't people been addressing surgery? Well, it's really hard and it's just daunting. And whether it's because, well, first of all, there's not enough people, but then we find out there's actually a lot of people that are affected by surgical conditions. So then the next thing is like, oh, well, just surgery in general is expensive. Therefore, it must be, if we have a lot of people that need surgery, that's going to be expensive. However, actually, this DCP3 volume suggests otherwise. it says that essential surgical procedures are among the most cost-effective of all health interventions. And because a lot of them that have been listed and brought up by this volume are delivered at the first level or district hospital, it's really, really important to invest in this platform and make sure that they're geographically spread out and whatnot. And yeah.
Yeah, I think this is a really, really good point. Surgery is very cost effective. And I think the myth, quote unquote, that surgery is expensive is not a myth. Surgery can be really expensive to implement, and it is one of the things that that we kind of need to take into account as we're thinking about implementation. However, it's not. It is expensive, but to say it's too expensive is to say that we're not getting enough value for what we're paying. And as Sultan already said, the return on investment is huge. The return on disability, as Jamie said, is absolutely huge. And I think as we start thinking about ways to implement surgery, we need to bear in mind that $3 billion a year sounds like a big number to us, but that's for the entire world. And for the entire world with a $70 trillion GDP, $3 billion is a rounding error.
So Jamie, what do you think are some ways to bring down costs for surgery?
Well, clearly, technological innovations are going to bring down costs, task shifting, economies of scale, and all of these things have been talked about a great deal. And they've been proven, they're very important. But let's put everything into context, right? If you put the cost of a single surgery, so for example, cataract surgery, estimates show that for a single procedure, if you bring it down to the level of an individual patient, it's about $35, right? But you measure it against, I don't know if you even think about measuring it against DALYs, QALYs, not even that. Just kind of envision the lifetime, right? The lifetime economics of a fully functional member of society, right? There's no contest in any government that isn't willing to cover the costs of these essential childhood surgeries. They're committing economic suicide. I mean, it doesn't benefit anyone economically to prevent people from having access to these surgeries for economic reasons.
And that leads us into the next point about access to surgery and another myth and misconception about treating surgical disease globally. So the idea is that not only could it be, well, again, it's a myth that it could be hard to treat and very costly, but the other point is that it's not feasible in low resource settings for a lot of those reasons about just being difficult and costly. But again, this isn't true. There are many examples where their access to, capacity for, and the quality of care has been improved. For instance, one example is with task sharing, as Jamie brought up. This is an effective and affordable measure that's been shown to increase surgical care access at the same time as increasing capacity. And emergency level procedures dominate the list of what could be delivered at the district and community level health centers. So as I mentioned before, it's really, really, really important to invest in these platforms, not just for the cost effectiveness, but also just because they are the major platform that these surgical procedures are going to be getting delivered, and therefore they need to be available and spread out, appropriate geographically for the people so they can access it. But I want to ask Mark and Jamie, what are other ways that you think we can increase access, and what do you think are some of the challenges with doing so?
So just for those who may not know what task sharing is shifting the person who does surgery from the fully trained, I've been in school for 15 years surgeon, to a mid-level provider to do sort of a limited bundle of surgical services. I think task shifting, task sharing has a huge role in doing this, but getting to the cost effectiveness question of it and getting to the challenges that it faces, one of the challenges that it faces is that, and one of the things we haven't talked about really yet, is that even if surgery is cost effective, it may not be affordable for the individual patient. And as we roll out something like task shifting, as we roll out something like increasing the workforce, the surgical workforce in a country, we need to realize that that's going to draw out some demand for surgical services that patients may have that they couldn't get because there wasn't a surgeon there. But that surgeon, that task-shifted provider, isn't free. And we may actually counterintuitively worsen the financial status of people who are getting surgery. So as we're rolling out these things, and we've done some research to show exactly that with task shifting, as we're rolling out these things, we need to keep in mind that medical interventions, surgical interventions, act on an axis of health, but they also act on an axis of financial risk to patients. So we need to make sure to keep both of those in mind.
Let's start by saying access to surgery has multiple dimensions. So when we think about it, we have to think about it in terms of the availability of surgery, affordability of surgery, accessibility, and attitudes towards surgery, which is, when you bundle it up, also can constitute really the significant barriers to surgical care. So I would like to, I'm going to point out two instances in terms of challenges, right? And this is something that we've discovered on the ground. So for example, people think that in some places surgery is not happening, which is not true. There are surgical procedures that are happening. It's just that there are some people who are so hidden they're in the far-flung regions of a country that they can't get to where the surgery is happening, or they don't know that it is happening. So transportation and information on where this is happening, even contacts within the healthcare system, those are significant challenges. They just don't know how to access it from that standpoint. So case in point, when we were filming, we made the film, The Right to Heal, and I'm going to talk about that later. We went to 7 countries, and there was a remote island in the Philippines where we found a child. His name is Yuan, and he was 5 years old, and he has a part of his intestine outside of his stomach. So what happened was that when he was born, he had what you call an anorectal malformation. He did not have an anus. So the surgeons, in an emergency, diverted him. So they created a colostomy and left him there. And they thought that that was how he's going to be for the rest of his life. So he didn't want to go to school. He was malnourished. And we found him. And what we did was we flew him to Manila, the capital, and he had surgery to reconnect him. And now he's back in school. He's gaining weight and he's had access. The second example would be cultural. There's a cultural barrier to surgery. So for example, in Mongolia is one of the least densely populated regions of the world, but it's a huge place. And there's a huge nomadic lifestyle. And also there's farming and herding cattle is one of the big what they do for a living. So for them, if you tell them you're going to have surgery and you're going to be out of work for 2 weeks, they're going to be like, no way, that's not going to happen to me. So, and one of the most prevalent diseases in Mongolia is gallbladder problems. And at that time, you have this big incision, right? But when they introduced laparoscopic surgery, where you have small incisions, instead of 2 weeks that you're going to be out with traveling and all, it's going to be 2 days. That significantly changed people's perception of surgery. So instead of them saying, no, I'm not going to have the surgery because I can't stay away from my family, they say, oh, 2 or 3 days, fine. So they go and they have their surgeries done. So something high-tech like laparoscopic surgery actually changed people's perceptions because that's what they needed. And that was culturally acceptable to them.
Yeah, this is definitely great discussion talking about access, both supply side and demand side. My next question for you guys is, how do we increase capacity for surgery in low resource settings? And I know, Mark, you talked about task shifting, but in terms of training, a lot of countries, lower middle income countries have very limited surgeons, and as a result, medical tourism is extremely popular. How can we increase capacity by increasing training? How is that feasible? Is there something being done on that?
I think the increasing capacity in countries is a huge question, Sultan. I think you're asking the exactly right question. And there are a number of innovative ways of doing this that are out there that are pioneered in certain countries. We don't necessarily have to replicate what we do in the US or the UK in another country. There are countries, Ecuador, for example, is a really good example. There's a group in Ecuador named Sinter-Andes that has trucks, and they go into sort of the hinterlands of Ecuador where people, like Jamie was describing, that really can't leave their farms, can't access surgery. Well, they bring the entire surgical ecosystem to them. Zambia does the same. There are NGOs that do this. Orbis does this in ophthalmology. Mercy Ships does this for 7 different procedures. So yes, we absolutely need to increase the manpower, but that takes a long time. And in the interim, there are a number of innovative ways that we can think about getting surgery to people who don't otherwise have it while we're training the surgeons. One side is, of course, supply side when you're talking about is training and having doctors. What about tools? Is that a concern as well that you've seen in low resource income settings? And are there innovations that you've seen that address those gaps in terms of supplies, blood, tools or machines? There are definite innovations in the sort of physical infrastructure that's necessary for surgery. There's innovations in Rwanda around a low-cost vacuum dressing. So some wounds heal secondarily. You leave the wound open, you let the body heal the wound, and that can take some time. And putting a little bit of suction onto that can increase the speed of that. And there are super fancy vac machines that we have here. You don't need a super fancy vac machine. You can make one. In other places that I've worked, we've made positive pressure ventilation for young babies using just saline and some tubing. So there are innovations around it. Our innovations are not just around the physical infrastructure. You mentioned blood cells, and we are so used to in the States having a blood bank in each of the hospitals in which we have donated blood that sits there waiting for somebody. The military uses direct person-to-person whole blood donation, which some countries have also started doing. Take the blood out, screen the blood right away, and then give it directly to the patient whole without all the other fancy stuff that we do to it. It's low cost, and it is, so we don't necessarily have to innovate in just making a cheaper anesthesia machine or making a cheaper X, Y, and Z. We can also innovate even around the way we do things.
I want to go a little broader. We've already talked about how cross-cutting surgery is within health in general, in that sector. But I know, Jamie, you are also interested in the linkage between surgery and the SDGs, which is all different sectors. So I wondered if you could speak on this a little bit.
Yeah, absolutely. So I'm going to go backwards and say in the year 2000, the world decided, you know what, public health, we need to ramp up our efforts. So they united and chose 8 development goals, and it worked, right? They've really brought down maternal mortality, and based on that success, they said 2015, which is the deadline of the MDGs, let's think about sustainable development goals. Let's go further and let's be more bold. And so they created the sustainable development goals. And one of them, goal number 3, is ensuring healthy lives, right? It's all about health. It's all about sustainability of that health system. And if you look at that goal, there are targets within that goal. And surgery actually addresses 5 of those targets. And one of them, maternal health, child health, injuries, non-communicable diseases, and universal health coverage. So if you think about it, without surgery, you will not be able to fully ensure sustainability of your system, right? Because when a mother gives birth and gets obstructed, you will need surgery, right? When a child has congenital deformities, you will need surgery. And all of those things, cannot work without a fully functional system. So surgery can strengthen health systems, can complete and give true universal health coverage to these existing conditions. And I cannot imagine a world, right, in 2030 where we wake up and all of those countries say, yeah, we have universal health coverage. Oh, wait, but my mother who just, had a baby too big for her cannot have C-section. That's not universal health coverage for me.
I very much agree with what Jamie is saying. I think if you said to me that you had founded your own country and you were developing your health system and you thought you could keep your whole population healthy without surgery, I would wonder what you were smoking. Mm-hmm. But I think it also goes even further than what Jamie said. Goal number 1 of the SDGs is the end of poverty, and goal number 5 in the SDGs is for gender equality. Both of those are so wrapped up in surgery. Women are less likely to be able to get surgery in many countries. Surgery, as we talked about before, can be catastrophically impoverishing for patients who try to get it. So if we do surgery right, we're not just impacting goal number 3, which is the health goal, as Jamie said, but we are also potentially impacting a whole bunch of other SDGs that don't even seem to be related to surgery on the face of it, but really are.
That's a really interesting point that you've made, Mark. And, obviously talking about gender equity. And I do remember reading that, how the need for surgery is greater, not only in women, but also in a lot of marginalized communities. I also wanted your thoughts on what about emergency situations such as Haiti or Syria? How can access to surgery or surgical care be improved in those kinds of situations?
That is a great question. One of the things that scaling up a surgical system does, in addition to just giving people surgeries, is that it makes the system relatively resilient. I'll take Ebola as an example. Ebola obviously is a non-surgical disease. We don't need to do surgery on Ebola. In fact, we try to avoid doing surgery on Ebola patients. However, one of the reasons that the Ebola epidemic of 2014 was so massive was not because the virus itself was any different necessarily, but because the health systems that it was in were particularly strained. And if you scale up a system, if you scale up a surgery, you scale up an ecosystem that requires constant sterilization, which surgery does, then you have a whole system there to do that sterilization, and you don't have to make it up as you're going along. Translating that to Syria is difficult, and I'll leave that harder question to Jamie.
No, so I think that if you strengthen the health system overall, when an area gets affected, that it goes down. You have the surrounding networks around it that's relatively close. If you're gonna wait for someone from the US to fly in, and then you have everyone flying in, and it constitutes a bottleneck, right? Then you're in 24 to 48 hours go by, right? And we know that injury, you have the golden hour, and you have that period of time where you can make the most impact in saving lives. Really, from a logistics standpoint, you've already failed. So really strengthening the networks around it, and relying on local providers that you've already trained, that you've already had the disaster preparedness that's built into what they do, kind of really easily move in and fill the gap. Then you've created the safety net for surgical care.
Now, Jamie, I know, and you already mentioned a little bit about your experiences in the Philippines, and I understand this led you, or at least influenced, a project that you were on, a film project called The Right to Heal, where you were the executive producer, director, and writer. Tell us a little bit about that, and I wonder if you could, while you tell us about that, how has this project been helpful in advocacy efforts around essential surgery?
Yeah, sure, amazingly. Having grown up and lived in the Philippines, where I spent more than 20 years grappling with, and Mark really aptly, thank you for bringing up the fact that, surgical care, lack of access to healthcare, and poverty are linked, right? The gap between the rich and the poor really is so huge that when they can't access healthcare, they get even poorer, and then they go down, and then it's called the really the terrible cycle of poverty that's there. And how do you break that cycle, right? And for me, healthcare is really one of those things where you can make a difference. Doing the work with global surgery and going around, I spent about 3 years in the global surgery academic circuit, trying to understand and trying to really think, how can we make a huge difference, a dent? The problem is so massive. And it was really out of frustration. I just I wrote some papers, they didn't really do anything. And I, waiting for something to change, I just said, all right, why don't I just stop speaking, pick up the camera, and just show people what's going on. Let the patients speak, let the providers on the ground just tell their story. And we're all human, right? And it's something that you can't really, that's truth that you can't ignore. So The Right to Heal was born from that frustration, really. And I just asked around and said, do you know someone? And yes, obviously people knew people who had this kind of problem. And we went around and did, one country to the next. Before we knew it was 7 countries. And really it was, I used the Cine Verite style of documentation where I was on the ground, I was open, and I let them educate me. And it was really their voice that informed the film and created the film. It was, I was just merely a conduit for it. But the result was massive. When we showed it to everybody, the response was always, how can I help? What can I do? And we went from Hopkins, we went to different organizations, we went to we went to the UN, we went to WHO. Then we found ourselves in front of ambassadors, countries, and it opened up so many doors and really brought home the point that what we're talking about here is the neglected surgical patient. And you, like a person who's been in public health, only thinking about infectious diseases, then kind of just started to have a grasp of what do we mean by surgery in public health. And we used that film to advocate and say, let's push for a formalization of doing something for these people, meaning what about a resolution for surgery? And really planted it in people's minds. 2015 is the year we kind of, sort of in a way awoken them to the issue, but then offer the pathway, because then you say, this is a problem, there's no solution, right? And people just get frustrated and they go home. So it was basically when they say, well, what can we do? We said, well, we want you to support the resolution. We want you to take this to places where it's never been before in your capacity. And so it really paved the way for a lot of, at least a lot of effort in terms of moving in the right direction for surgery. And it's the voice of the patient, really, that motivated people at the end of the day.
This is such a great example, Jamie, that how voice of people can bring attention to an issue that's been called a neglected stepchild of global health. One other question that I have for you is, how can we best mobilize public citizens, private citizens, as well as private stakeholders, private sector, as well as governments to support safe surgery? How do we bring this issue on top of the agenda?
Right. Thank you for asking that question. The question of mobilization of public and private sector and governments, right? Again, that's been a question that's all in our minds, right? Because we know you and I, we have our voice, but if we put it all together, right, then it becomes more powerful. But not just that, we go a step further. We actually institutionalize the issues, right? And so that's why we thought of bringing together all the like-minded or powerful organizations in the field. Organizations will live beyond us, right? So then that's why we created the Global Alliance for Surgical Obstetric Trauma and Anesthesia Care, which is all about advocating for the neglected surgical patient. And now we have about 86 member organizations. And this, and you ask yourself, well, what is the power of this? How can this make a change? Case in point, the Lancet Commission actually published a set of surgical indicators. And at that time, WHO and the World Bank also published these are the 100 lists of health indicators that all countries should collect. None of them had anything surgical in it. And we said, no, you have to put surgery in there. And an email, this and there didn't really work. So we said, let's mobilize. So we gathered 140 signatures from surgical obstetric trauma and anesthesia organizations all over the world to support the indicators, and wrote an open letter to the WHO World Bank. And the next edition already had surgery in it. So there's power in it. And from there, we have to move on to the next step, right? How do you actually bring that capacity down on the ground so that at the end of the day, you will be able to provide that surgery to other people? That's the next step for us, right? So from the top level, going all the way down to the grassroots level, and mobilizing civil society and giving them a pathway and telling them, well, you wanna help, you wanna participate. Here's exactly how you're gonna do it, step by step, and that has shown a lot of at least some leeway with organizations who've been wanting to do something at this level for a long time.
And I think that's a really great place to kind of end things. And our discussion today is really, how do we get people motivated and mobilized to really do something and help get people more access and get essential surgery, really, at the policy level, people discussing and doing something about it. But since we are ending, and I know that you guys are very passionate about this issue, I want to let you guys, is there anything that you want, to say about this issue that we haven't covered already that you think we need to really drive home at this point?
I want to end, first of all, thank you guys for having both of us on this program. I think the last thing that I want to say is surgery has been some of the myths we've been talking about. Surgery has been viewed to be such this complex thing to do and such a hard thing to do, and it's because you literally have to bring the means of production of surgery to the individual patient, and so you have an entire ecosystem that you have to build up, which is true, but which is exactly the reason to be doing it. Because when we start doing that, when we start building up this ecosystem, we've built up the electricity, the water, the sterilization, the training, the everything that we need to do in a hospital. So it is, in global health speak, it is the quintessential horizontal intervention, because we've got to do everything to fix surgery, which makes it also a really exciting place to be working.
Yeah, I want to say thank you, Jessica and Susan, for organizing this and inviting us to express our life's work, really, right? Our passion and everything that what motivates us and why we're doing this. And it's so important to actually have you guys to be the organ to spread the message out, because this is something that I always say, it's not one person. It really takes a whole world to create the change that we want, and if we look at, if we wake up in 30 years, right, and you would see that child having access to surgery, you would know it's because of you, right? And awakening people and showing them that it is possible, it's very doable. Here's how, even just starting to talk about it and understanding and really piecing out and clarifying all the issues, and then understanding where do we go next, what's the next step, and what can you do in your capacity. It's already huge. And I think this is an exciting time for surgery, where this is surgery, essential surgery, global surgery has never been in this space before, and we have the potential to sit alongside, right, the HIV, TB, malaria, sort of big group, because it is important, and I'm excited to be kind of alongside you guys, working on this together. So thank you.
Well, I want to say thank you, Mark and Jamie, for joining us. Your passion about this issue is just so evident, and it's, that's what inspires people to do things. So it's been great having you on there, and it's been great to learn about essential surgery, and hopefully our viewers that have hung in have also enjoyed learning about these things. And I just want to say thank you to our viewers and audience for hanging in. And if you want to learn more about this issue, you can read the volume, the DCP3 volume, that is available at www.dcp3-org. And if you want to watch any more of our videos, we're going to be doing a whole series on the different issues covered by the DCP3 volumes. So tune in. We have our own YouTube channel at This Week in Global Health, and we invite you, especially if you really have enjoyed the topic, to comment on our videos, raise some questions, join into the discussion, or you can even tweet at us. And we all have our Twitter handles up there, so please do so. We love hearing from our audience. And please subscribe to our YouTube channel. That way you can get updates on what's coming up and the newest videos. But you can find us on our webpage as well. And there's a number of other places where you can find us and learn more about This Week in Global Health, like LinkedIn, Twitter, and Facebook, and Instagram. And we even have a blog. So, oh yeah, and then one more thing. So if you're really more of a listener rather than a watcher, we also have an audio podcast. And so we'll have the whole discussion of this episode on that as well. So again, thank you for listening. Thank you for watching. Thank you, Jamie, Mark, and Susan, for joining me tonight. And we will see you next time. Bye.